Hello everyone, welcome to the first webinar in our Patient and Family Engagement series. Today's topic is Volunteer Management Part 1, PFA Recruitment, Screening, Interviewing, and Database Management. My name is Annie Allen. I am a Clinical Quality Improvement Advisor at the Wisconsin Hospital Association, and I will be coordinating today's event. For those of you not familiar with this technology, we are using a web-based video conferencing platform called Zoom. As of now, all of your mics are muted and all of your video feeds are active, meaning if you have a camera attached, it's on. This is meant to be an interactive event, so if you have a question during the presentation, go ahead and put it in the chat box and Jenna will answer those questions as they come in. Otherwise, at the end of the presentation, we will unmute all of the lines. So if you would like to say something at that point, unmute your own line by clicking on the little microphone icon at the bottom left of your screen. If you're on the phone, then you'll need to press *6 to mute and unmute. Jamie will also put these directions in the chat box for you, and you can always put your questions at the end in the chat box also if you'd like. This event is being recorded and will be available for access in the Quality Center. So let me now go ahead and introduce you to our presenter for today, Jenna Wright. As Program Manager for Patient and Family Advisor Partnerships at UW Health, Jenna has gained extensive experience engaging patients and families in improvement work at a large academic medical system. She came into this role in 2017 with over 20 years of experience in adult education and training in academic and business environments, focusing on spoken and written communication. Her passions include health literacy, human connections in healthcare, and patient and family engagement in all aspects of healthcare design and delivery. So now I'm going to hand it over to Jenna.
Thank you, Annie. Thanks for joining me today on your lunch hour. So I want to thank the Wisconsin Hospital Association for hosting this webinar series. We do have four parts of the series. So today, like Annie said, we're going to talk about PFA recruitment, screening, interviewing, and database management, kind of the basics of volunteer management in a patient family advisor program. And then we'll move on in July and talk about orientation and placement, how we can retain our best patient family advisors and offer recognition for them. And then later in the fall, we'll look at how to build the demand in the organization for that PFA engagement, focusing on internal marketing and project development with many stakeholders. And finally, engaging our staff and supporting them as they work with advisors and celebrating and sharing outcomes. So those are the four parts, and I hope that you can join me on this four-part series as we go. We are based in Wisconsin, Madison, Wisconsin, but also have a presence in Rockford, Illinois, and across the state. We do have 87 clinics and 7 hospitals and a number of joint ventures crossing the care continuum. And by the numbers, we have a lot of people working for us. We have about 1,800 physicians, 700 or so residents and fellows, around 20,000 staff, and you can see the rest of the stats there. We also have, that's not listed here, we have about 1,200 volunteers and 200 patient family advisors in the program that I coordinate. Okay, so we define our patient family advisor program as working with partners, UW Health and patient and family advisors seek to transform healthcare delivery by providing a forum for the patients and families' voices to be heard and understood. So this statement was actually written by patient family advisors in their words, and I think it's a really common sense sort of definition. And I also use a different definition when I talk to staff because I feel like it's a little more concise and it uses all the buzzwords that people like to hear when they're thinking about improvement. So for staff and providers, I generally refer to the program as our structured program for patients and families to engage as stakeholders in improving quality, safety, and patient experience. All right, we've had a really successful run with our program. We enjoy having patient family advisors on board because they really offer a fresh perspective and don't bring the sort of bias that we might see from healthcare professionals. They're not concerned about efficiency or what's cheaper or has a cost savings at all. They're definitely interested in the human side of healthcare. So for example, we were doing some facility design recently, And our designers came up with all these great ideas for electronic and technological ways to interact with patients, like e-check-in and so on. And our advisors were very concerned that they thought that that was going to replace humans. So we had to assure them that every bit of technology that we employed would be in addition to the warm human interactions that they would expect. So I think the designers hearing that from patients themselves just helps keep that in perspective so we don't go the wrong way. And of course, patient family advisors know more about how we work together than we know how we work together sometimes. So, a lot of times healthcare employees work in silos and we don't necessarily know how we are interacting or how we're affecting what's down the line for a patient. And they can share that with us so we can learn from them. And my favorite quote is from one of our advisors who said there that she's been able to share real stories about how her daughter's health and well-being was impacted, which is not just about making a system work properly in a flow chart. It's about real people and real lives. And that happens across all of our improvement projects that advisors are part of. So our program really started in about 2006, and it began in a small office as part of just the hospital. So just in our patient relations department, they wanted to start a little program like this, and they had one director and one assistant working on it. They started with 2 advisory councils, one for the adult side of the hospital and one for the children's side of the hospital. And that development lasted for a few years. And then in 2013, they decided that they really couldn't manage the volume of work that was coming in with the director of the patient relations department who might have had some other things to do. So they made an FTE for a full-time patient family advisor program manager in 2013. And that person got to dedicate all their time to rapidly expanding the program, recruiting lots of new advisors, creating more councils and committees, and then really laying the groundwork for the future of the program by establishing standard work, like documents, guidelines, processes, putting the website together, all kinds of good stuff like that. And these days, our patient family advisor program has expanded to cover the system. So we went through some changes as an organization where the medical practice side and all the clinics joined with the hospital side. And now we've got more mergers, and you know how these things go in healthcare. So the PFA program is now system-wide. And we have 200 advisors covering 11 councils and annually about 100 to 120 committees and projects with PFA involvement. And one of my favorite things that we're doing these days is a hybrid volunteer program, which I call PFAs on assignment, where advisors are out in our environment, really observing and giving us feedback on how we're doing in real time. And I'll share more about that a little bit later. So as far as recruitment goes, we do have a lot of opportunities for our advisors, and I think that helps create a space for really anyone who wants to contribute. So I'll share with you some of the things that we're doing with our patient family advisory community, including PFACs, standard sort of committees, work groups, focus groups. We have a pretty good e-advising program, PFAs on assignment, as I said, and then a public speaking program that we call Voices of UW Health. So as far as our advisory councils go, these are the ones that are either current or in formation. So we still have the Children's Hospital one, a new group for cystic fibrosis for pediatrics, and we have one that's in formation for cystic fibrosis for adults. And as you may know, they can't meet together in real space, so we're looking at some more remote attendance type of technology for them. We have a heart vascular thoracic group. We have one of our clinics has their own group, Northeast Clinic. The NICUs, the joint NICUs between the American Family Children's Hospital and Unity Point Health Meriter, we do share faculty, and also the patients move back and forth. So those two NICUs have one group. My chart meets sort of ad hoc, but pretty often. Oncology, behavioral health covers all mental and behavioral health services. Transplant, many people are inspired to give back after receiving a transplant or participating as a donor. So that's a really robust group. And then UW Health is another group that is really over patient issues in general. So anything related to billing, insurance, facility design, any of the big initiatives, strategic planning, that kind of stuff will come to that larger group. PFACs, I should say, are groups of about 12 to 18 members, and there's usually 1 or 2 staff coordinating that effort. And they meet usually monthly, bi-monthly, or quarterly, depending on the need. And obviously, you can see here that they focus on a certain health condition, or sometimes a facility or a healthcare issue. We also have a number of standing committees, and committees are a little bit different because the staff are invited to join the work. The advisors are invited to join the work of staff. So in committees, there might be 5 to 10 staff members and maybe 1 advisor or 2 advisors. And that work is going to continue regardless. So we're happy to invite in patient family advisors to contribute to committee work. So just some examples that we have there are listed, and they would meet generally monthly, depending on the work, and these are standing committees that go year after year. We have about 80 to 100 committees and also short-term groups that meet through the year. So short-term work groups really focus on a need that can be met in a few months. A lot of planning work, strategic planning work, facility design work, short-term projects, like when we were rolling out Open Notes, all the communication related to that was informed by advisory input. And these types of work groups are really appealing for people because it's a little bit easier to commit to than like a year-long project. We have a number of opportunities through the year for electronic advising. So we'll send out surveys or other ways to engage with our advisors online. They've helped us craft our vision statement and our strategic plan. Sometimes they pick art or help us name a clinic, and sometimes review patient education or patient communication materials, and even update our website. So we've had a lot of really powerful feedback through e-advising. And again, it's a popular way to contribute, minimal commitment, and it's easy to collect all the feedback on the staff part as well. So my favorite thing is PFAs on assignment, which are patient family advisors who are out in our environment, interacting with people, places, patients, staff, and many ways that they can contribute include observing providers. We have a program called the Communication Advisor Program that sets advisors to observe physicians in practice, or APPs, and gives them feedback on their communication skills. A lot of the clientele for that would include residents, so we have a lot of partnerships with residency programs. We also have sent advisors out to just observe how patient experience unfolds in public spaces, like the waiting room or near guest service desks. And some of our advisors have experience rounding on patients for their experience or doing patient interviewing. And lastly, we do also invite some advisors into staff training opportunities. If it's usually a PFA informed project, they've been in it the whole way, so we'll invite them back in for the staff training. All right, last one is our public speaking program, which we call Voices of UW Health. So Voices offers opportunities to match patient family advisors with speaking events. Sometimes they're live events. We do a lot of work with the School of Medicine and Public Health. They are looking for speakers on various topics for their students. So we recently did one on lung cancer, geriatrics, health literacy, and then sometimes they are live events for our own UW Health main organization, and that would include something like Safety and Quality Week. We often also record and distribute videos on patient experience tips and some orientation and training opportunities, and have a pretty active social media presence with our advisory group, sharing stories, giving advice to staff, inspiring patients. So we try to engage them in ways where they can really make a difference, because that's what they sign up for. All right, so of all of those things, sometimes I get questions like, where should I start? Let's say you have no program at all and you're wondering how to start. Most people, of course, start with patient-family advisory councils because they're kind of controlled environments where there is limited, like 1 or 2 staff who really take care of those advisors and they can feel comfortable with each other. Sending patient-family advisors out into committee world can be a little unpredictable because the staff people have multiple priorities. They're trying to get the work done. Sometimes advisors need a little help, which may or may not be offered by the committee chair. So you'd have to really be confident in the abilities of your advisors to send them out to work, partner with staff directly like that. So usually patient-family advisor councils are good places to kind of help them get those skills to speak up, have that sort of ability to partner in that way. E-advising is very easy, and I think that helps. It helps keep people engaged, even if they're not on an active assignment. So I like to send things out to get people's input, even if it's like, hey, take this quick survey. That way there's a constant touch point with the program, even if they're not actively in a committee, or maybe their council doesn't meet for another 2 months. I just want to keep in touch with people. And then, of course, the PFAs on assignment and Voices of UW Health are more selective programs, and those can be developed later as you would need. But, you know, you can find different ways for people to engage depending on their skill level and the needs of the organization. But yeah, I'd start with councils and then really train up your committee leaders to engage patient-family advisors appropriately. If I was starting a new program, which, you know, this program has been around for a long time, so I have the luxury of saying that. But I know that if you're kind of on this beginning of this journey, you might be wondering where to start. All right, so let me show you a little bit about how we bring new advisors on. We look at their application, and I'll show you that. We do a phone screening interview. We have a review process that includes a patient relations review. Some positions get a background check, and there's an orientation. And then finally, placement. So today we're going to talk about, also after placement, then usually there's a staff person who continues that onboarding. So today we're going to talk about the application, the screening process, the review process, and then the rest of that is really for the next webinar in July, because we're going to divide PFA volunteer management into 2 sections. So as far as the recruitment goes, I think the main avenue that we get new interest from potential advisors is through our website. We do link this website through volunteer services, and there's a reference to it in the patient guide, which is online as a PDF, and then also in the patient rooms. We used to have it linked from patient relations page where people would go to submit their complaints and compliments, but we found a pattern of people who came from that page were more interested in solving their own problems than helping the program at large. So we decided to disable that link and just focus on the volunteer services and patient guide links, because that's where the people are probably there for the right reasons, trying to help. And so you can see our main page has some general information about the program, an application, some sort of testimonials from advisors and staff, some of the opportunities that we have to get involved, and it's just kind of the first landing page for a lot of folks to come on. Other ways to get interest in this program would be posters and postcards. You can see there the poster that we have. We try to use really plain language to make it as accessible to as many people as possible. So your input is needed. Just really, I think, catchy, and then a clear explanation of what patient-family advisors do and how to learn more. So that poster is distributed around the organization. We have a smaller version that's on 2 sides, basically the same information. It's a postcard. We also have digital displays on our LCD screens in all of our facilities. It is in the hospital inpatient guide. So again, that's a digital document and a paper document that all patients get in all of our hospitals. And a lot of people do come through staff and provider referrals, so they might have had a powerful experience that they want to use to make things better for the organization. So we'll get some staff and provider referrals, and sometimes we'll get advisors who refer their friends. And that can be good sometimes, and sometimes you can get a lot of the same kind of people from patient-family advisors. But in our case, you know, sometimes we really need, like, for example, younger people. So if I have a younger patient in their 20s, I might say, do you have any friends who might be interested in this? Because I really need to build that population. But I wouldn't necessarily do that for people who I already have enough representation from. So once someone clicks on the website and it says apply now, they'll be sent to this interest form. This interest form collects really minimal information, and you can kind of see what we gather there. The why are you interested in becoming a patient-family advisor section there, they can type as much as they want in that box, but usually people, you know, really briefly describe why they're interested. And this is always followed up by a phone call, so I never need to worry that I'm not going to get all the information that I need. We used to have a really lengthy application form which asked great detail about their health experiences, and I found that I didn't want to be responsible for maintaining all of that health information, and I felt also that advisors or potential advisors didn't want to share all of that without knowing where it was going and what was going to be done with that information. So we kind of leave that out, and we follow up with a phone call or an email and then a phone call to kind of see if we're on the right track. What we're looking for when we are screening for effective patient-family advisors are those who really are there to help improve patient experience for future patients, and they're not there to solve their own problems. We are looking for people who communicate in a constructive way about their experiences, and that they represent our diverse patient base. So with each counselor, each opportunity, we are trying to balance out, you know, age, race, sex, healthcare issues, all things about people. So we want lots of different kinds of patients so that we can make decisions that anyone would find is representative of the group. So to that effect, we're looking at some interview questions here. So this is all a phone screening interview, and I have some questions here that I ask pretty much every time, and each one of them has a goal. So the goal, the first goal is to figure out how do they learn of the program. So I'll ask, you know, how did you learn about this opportunity, and I'll learn whether they experienced their first contact through the website or a friend or a provider, and I'll just kind of track that so I know where to focus my energy for marketing. I do want to make sure they're eligible, so I'll ask if they actually do receive care at UW Health. You would think that's a given, but we do have some maybe students who are trying to learn more about healthcare who want to join, and they're not even our patients, and so those types of folks wouldn't be eligible. And then I think the most important thing in this whole set is ensuring a shared purpose. We are trying to make sure that that the people who are coming into the program understand what it is and that they are there for the right reasons. So I'll ask, you know, I'll kind of share the purpose of our program, which is to give advice to UW Health to make patient experience better for other patients. And I'll say, does that match with what you're thinking? And sometimes they'll say, well, I really wanted to partner with patients directly and help guide them through their experiences. And that's not part of what we do, so we'll have to be sure to clarify that for them. And then definitely we're not there to be an extended sort of patient relations portal. So it's not there, we're not there to help them solve their own individual issues, but to kind of help promote better quality for the whole group. And then I do like to spend a little bit of time even on the phone getting to know the person. So tell me about yourself. Are you working? Are you retired? Any special skills or interests? And sometimes I'll learn, you know, if they're working or if they're retired, that helps me think about, can they attend daytime meetings or is it just more evening meetings? If they have any special skills, maybe they're in their career, they're an editor, and ooh, that would be great for our publications review. Or if they're interested in, you know, a certain subtopic, then I can maybe think about placing them in that. If they're a really good speaker, if they've been a trainer, then that would help me think about placement a little bit early. I try to learn about their style for providing feedback. So I'll ask the question, like, tell me about a time when you saw an opportunity for improvement and how you went about, sharing that with, UW Health or with their provider. And then I'll learn if, a little bit about their style for providing feedback. Like I said, if they're they see things from many angles, if they're constructive or if they're kind of abrasive, or, how they kind of think about things. And that really helps me with a little bit early placement, like, are they going to be good in this kind of committee or that kind of committee? And then lastly, I'll ask if there are any specific topics or services that they're interested in. So they might say, oh, I'm really interested in pediatrics or, children's care, or I'm interested in oncology care. And I'm not going to ask them, about their health specifically, because I don't want to know all that. Like, I'm not going to ask about healthcare specifically, but I will ask about their services or issues that they're interested in. And I don't want to, pry too much. But then later on, if they want to sign up for something that requires a certain care experience, that will be listed as a prerequisite. So if they want to join our Oncology Advisory Council, they would have had to have been treated at our cancer center. So that's just part of that. And then they could reveal that at that time if they would like. The next step is we will ask permission to request a review of their record that would exist in our patient relations database. So this screens for any abusive or threatening behavior, any legal action that was threatened or enacted, any grievances that are not resolved yet, or negative contact with media. So they will, sometimes we've had people who didn't tell me that right away, and then I found out later. So it's a good conversation starter to find out, why they're really there. And sometimes they're there because they're trying to solve, again, their own care issue. If there is a grievance pending, it doesn't mean that they can't become a patient family advisor. It just might mean that we need to wait until that's resolved, because sometimes the outcome might affect their ability to contribute. So if the outcome is resolved to their satisfaction, they might be a great contributor. If not, then that might jeopardize the way that they contribute. Some programs have further screening by staff, depending on the sort of need. So, for example, some of our programs are by referral only internally, like our Patient Family Advisory Council that works with our HIV patients. Those are all referred through their social work group. And so if I ever had an external applicant, I'd have to run it through the social workers. Okay, so when you're, you start to build all this information about a person, how do you manage it? We actually have two ways to manage our prospective and active patient family advisory data. And one is VISIS One. VISIS One is it's a database that I share with our volunteer services department. So it collects all of the demographic data. We keep track of their training, certifications, things they've done. So once they do their orientation, that'll be listed there as complete. Any assignments that they have and their hours that they've completed. And that's their data if they need it for like if we need it for an internal review, or if they would like to access it for their records. And then on my side, I really work more in Excel, to be honest, because the VISIS One database is a little bit clunkier to pull information from. I'd have to create reports. So I just maintain a separate Excel spreadsheet. And there I track the prospective PFA's onboarding steps. We look at I can maintain easy email lists, and then I can track all the projects with PFA assignments on that. So I find it a little more nimble to deal with than the VISIS One database. And I'll show you some of the fields that I keep track of for the list of prospective PFAs. So these are applicants. Lucy Smith is not a real person, don't worry. So I would keep track of obviously their demographic information. PR approval is patient relations approval. And then there's a phone screening that I keep track of, their orientation, interest, and placement. So those are just some of the things I keep track of. And then when that's all done, I'll move them over to the active list. And the active list, is a little bit more information. So again, the name, and I keep track of sort of high trust or place carefully. I'll explain that for you guys. So high trust means they are a really good communicator, they are reliable, and I can trust them if I sent them to like a committee with like a vice president. You know, like sometimes there are people who you are ready to place in those higher trust positions. Place carefully might mean that maybe they're not quite reliable, they sign up for things, but they don't follow through, or they've communicated in a way that is not effective for a group. So I'll be careful how I place them. That might be more, they might be more appropriate for e-advising instead of group work and so on. So I don't want to turn people away, but I might sort of control the assignment level that they have. Level there is, we have 3 levels. Level 3 just means they're cleared to volunteer in patient care areas. That's a whole set of clearances that they need to have, including health screening, TB tests, all their immunizations up to date and all that stuff. So that is something that not all of our advisors have to do. And also they would need a background check for that. But we don't need that for the general population of advisors. We'll track their, of course, their email address, because I can easily sort by that with filters. And then select, it just means that if I have a list of 200 people and I only need the 30 people that maybe are involved in our pediatrics, I might hit X in the select box, and then I can make an email list for all of the peds people quickly. And so I'll track that for, you know, and then that box would refresh and I would just change it every time I needed to make a new list. And then of course I keep track of if they're in a council or a work group. So those are some of the things that I keep track of. And there are many, many worksheets to my Excel life. I'm not going to share it all today because I have a whole set of things also about assignments. So all the project tracking is also done in Excel. Explain that. Okay. All right. So I just have some quotes here from our members. I do ask them, you know, about their experiences and why they're participating in the program. So these kinds of quotes can help drive recruitment because maybe people can identify something in it that would also motivate them to join. So I'll kind of let you read through those. A lot of gratitude in our patient family advisory community and just a willingness to help. Some people love learning. So there are a lot of different motivators for people, and I'll try to highlight that for any prospective member and just really try to tap into what it is that we can do to meet their need while they help us meet our needs. All right, so we really quickly went through the recruitment, screening, interviewing, and database management portion of the PFA volunteer management section. And the rest of it, I think, will really help fill in the gaps there. But I wanted to leave time for questions, which I think I more than amply left time for questions. So hopefully, if you have thought of questions throughout this, you can share those with us now, and we'll be happy to answer questions.
So if you are connected via computer, you can click on the little microphone icon at the bottom left of your screen and ask your question, and then mute it again by clicking the icon again. If you're calling in using a phone, you will need to press *6 to mute and unmute. And of course, you can also type into the chat box, and we will share those questions with Jenna.
I'll go back to the quotes because they're more interesting to look at while we're waiting.
Hi, good afternoon. This is Ingrid Gunderson and Ellen Gianoli calling from Gunderson Health.
Hello there. How are you guys?
I'm good. How are you?
Good.
I should say we're good because it's 2 of us. First of all, I just wanted to thank you for sharing all of this because it's fantastic information and it's given us some things we need to do and look at, but also it gives us encouragement because we see that we're kind of in some places on the same page. And so that's really encouraging. I confess we might have been talking to each other. Can you explain to me what the levels are with regards to the data that you're capturing on your council members? And I have to say, I was very intrigued by the high trust and then, place carefully. I think that's a great way of classifying participation.
Yeah, thanks. So we have 3 levels of participation. Level 1 is people who really just give us information, so focus group members, e-advisors, people who don't receive information from us. To be honest, there isn't a lot of that, but that's how the system was set up some years ago. Level 2 is our entry-level patient-family advisor role, where they might be on a council or a committee, and for that, they just need to kind of follow those steps that I talked about as far as the application and the screening and the review by patient relations and orientation. And so then they can join meetings and contribute in that way. And then level 3 is patient-family advisors who want to have contact with patients. So anything where they're shadowing doctors or observing or interviewing patients in our care settings, that would require the background check, the health screening, TB, flu shot, all the stuff that volunteers have to do. So that's just another set of things that is a fun thing to get accomplished. But once we do, they are really happy to get out in our environment, and as they're learning, then they can bring that learning back to their committees as well. So they actually enrich their own experience and then help us see things that maybe we don't see because they're just out there talking to patients and staff and providers.
Well, and of course their eyes and their what they hear is more attuned to their perception as patients, and we may be seeing it, but we don't see it and hear it in the same way because we work within the organization. So I think that's a fantastic opportunity. Would you be willing to share like how many advisors you have that are at that level or how often that's happening?
Yeah, so we have about 20 advisors cleared to volunteer with patients directly. They are mostly involved right now in our communication advisor program. So there's about 17 people who do that, and they're shadowing doctors, mostly from our internal medicine and surgery residency programs. There's one every day every day this week in the morning where they're shadowing them. So there's about 17 people who do that. There was a whole month that we spent in our intensive care unit interviewing patients about their experiences with early mobility. So we directly connected with patients. The advisors interviewed patients about, what their barriers were for getting up when they were in the ICU, and how it felt to get up, and if there was anything that we could do to make it easier. And that was all fed into a quality improvement project. And so that we had one advisor there in the ICU every day for 2 hours doing interviews. And that was a beast to schedule, but it was really worth it. And then they used all that in their improvement project. So that happened for about a month. And then another thing that's really rigorous, and I want to expand, is we have one advisor who interviews patients for basically 3 hours on Tuesday and 3 hours on Thursday at one of our hospitals, and just says, how's it going? Are you comfortable? How's the food? Is there anything we can do to make your experience better here? And she gets better and more information than any nurse or doctor or survey would, because the patients just really open up. And it also provides an opportunity for real-time service recovery. So they might say things like, I ordered my meal an hour ago and it's not here. Or where's that popsicle I wanted? Or this thing is beeping and my nurse isn't here yet. So we can really get in there and kind of change the experience in addition to learn about it. Yeah, so those are some of the more exciting things. Yeah, so I'd love to spread that program to other sites.
I imagine it's somewhat labor intensive.
Yes, and there's just one of me. So
okay. Yeah. Thanks very much for sharing. That's really great stuff.
I know our model maybe isn't the same as what would be possible everywhere else. I think you guys have like one PFAC per site. Is that right?
We have currently 22 patient and family advisory councils.
Oh,
so,
22. Yeah.
Yeah. So 20 of them are kind of location driven. Yep. Some in our regional clinics, and then one here at the hospital. And then we have 19 are that way. 2 of them are disease driven. So we've got a diabetes and a cancer council. And then we have one that's topic driven, which is revenue cycle.
Okay, cool.
And we also do rounding on our patients, but that's through our patient experience department. We used to be called service excellence, now we're patient experience. And so we have staff doing the rounding that you just described. So I find that really intriguing.
Yeah, and we also have staff doing that, but they were comparing like what kind of information we get from both types of viewers.
Sure.
And there's actually a study that I just ran into at a conference where the woman in Canada, they showed that there is qualitatively quite a big difference in the information that people get from volunteers versus staff.
Fantastic.
I would think so.
Yeah.
Yeah. Well, thanks for sharing about your program too.
Oh, absolutely.
Yeah.
Thanks. We look forward to the rest of the topics.
Well, thank you. Yeah, I look forward to growing our patient family advisor council programs too. Like we have things in the works, like we'd like to start more of a digital patient experience group. There's a gender services group that might be starting. And another one that I'm forgetting right now. But yeah, there's definitely more interest. Oh, and more of a primary care. We don't have primary care represented as a whole group right now. So there's definitely some growth that we want to have there.
Those other 2 that you mentioned sounded incredibly innovative. So what a great way to go forward.
I hope so. Yeah, I gotta find my staff partners to really take over, because obviously those need to be housed in the areas that they're serving.
Yeah. And once again, there's one of you.
Right. Yeah.
All right. Thanks again, Jamie.
Yeah. Thanks.
So as you can hear, Jenna is just an amazing wealth of knowledge, and we are so thankful that she's willing to share. So please feel free to ask your questions. Chances are that if you have that question, somebody else who is either on the line or will watch this off of the recording also has that same question. So if you're by phone, go ahead and *6 to mute and unmute. The little microphone icon at the bottom left of your screen if you're connected via computer, and you can also type it into the chat box. All right, so last call for questions. Otherwise, we'll start wrapping it up and give everybody some time back in their day. All right, so hearing none, thank you all for joining us today. As a reminder, today's recording will be available in the Quality Center. Please join us again on July 9th, September 10th, and November 12th for the rest of our patient and family engagement webinars in the series. Thank you so much for joining, and have a great rest of the week.
Thanks, everyone.